A 20-year-old young soldier presents with history of acute onset of fever with chills and rigor of 1 hour duration, which is followed by multiple episodes of chills and rigor. 2 days later, he started having pain on the right chest, which increased on deep breathing, and he started coughing out a red, thick, jelly-like sputum. He continues to have fever and chills for the next 5 days and is now admitted. The patient has a history of diabetes since 1 year. He has no significant past or family history, and he has history of ethanol binge on and off.
Okay, so let's go to one by one. Okay.
Yes, sir.
Analyzing the symptoms.
So firstly, he presented with fever with chills and rigor.
Which system is affected after reading the story?
Respiratory, most likely.
Very good. What type of disease the respiratory system is having? Congenital, infective, inflammatory, degenerative, malignant, episodic, what type of disease?
So this is most probably a consolidatory, an infective disease.
Infective disease. So you have some infection of the respiratory system. So let's see details. It becomes a fever with rigor and chills. Yes? What do you think?
Yes. Sir, it could be a pneumonia or a viral fever.
When you have rigor, usually it is a feature of bacterial disease, pus forming. Rapid onset of fever can produce some bit of rigor, but very rarely in viral, more commonly with bacterial.
Yes, sir.
Followed by?
Malaria.
Followed by multiple episodes of?
Multiple episodes of fever and chills. And 2 days later.
Chills and rigor.
Rigor. Yes, sir.
Multiple episodes of chills and rigor. Is it significant for you?
Yes, sir.
Well, how does it help you?
Sir, the episode is going on. It has not resolved.
In relation to, suppose it's a case of pneumonia, how does this single episode of chills and rigor versus multiple episodes of chills and rigor?
So most likely there might be an abscess.
In pneumococcal pneumonia, characteristically, you have rigor and chills at the beginning. Unlike in Klebsiella pneumonia and staphylococcal pneumonia, where you have multiple episodes of chills and rigor.
Yes, sir.
You rightly pointed out, in pneumococcal pneumonia also, when they go to complications, you can continue to have rigor and chills.
Yes, sir.
Yeah.
So then he started having pain on the right side of the chest, which increased on deep breathing.
Yes. What does it mean to you?
Pleuritic involvement might be there.
Yes. Temporal profile of pleural involvement. Does it help you in any way?
So maybe
Pneumonia, beginning itself, you have pleuritic pain. Pleuritic pain appearing after 2 days, possibly other physiology factors are thought of.
yes, sir.
Then he's seeing out what?
So then he started coughing out red, thick, jelly-like sputum.
So when you analyze the sputum in a case of respiratory infection like pneumonia, what different colors you may have?
So it could be greenish, which can be seen in bacterial infections. It could be a rusty sputum, seen in pneumococcal. It could be red jelly-like, seen in Klebsiella. It could be black-colored, seen in coal workers' pneumoconiosis.
Cream color, you get in?
In cell.
Yeah. Suppose it's a viral pneumonia, a typical organism, what will be like?
It will be just cells, scanty sputum.
Scanty, there's not much sputum at all. The bacterial infection that produces sputum, and you rightly point out it could be a case of Klebsiella. Okay.
Yes, sir.
Yes.
So then he's continued to have fever and chills for the next 5 days, and he's currently admitted.
Then?
He He has a past history of diabetes since 1 year.
Is this diabetes something going on, or lifelong business?
Yes, sir.
The past continuous. Okay. So what's the relation between diabetes and intestine?
It could be a predisposing factor for pneumonia.
Diabetes is discussed as tuberculosis foremost.
Yes, sir.
Whenever somebody coughs, always exercise is mandatory. Always keep it in mind the possibility of TB. TB in diabetes is different from the conventional situation because it affects very atypical. In the sense, it doesn't affect the upper lobe, it affects the lower lobe. It may not behave like ordinary tuberculosis in a common person. For other pneumonia patients from diabetic patients,
Fungal pneumonias.
very classical is staphylococcal and Klebsiella pneumonia for diabetic patients.
Yes, sir.
And in these situations, fluid pain will not be at the beginning, but after 2 days. And here you have the clue that this is a patient having. And this is the clue. Klebsiella because of
He has multiple episodes of fever with chills and rigor.
It's also helpful. So who are the people who are likely to get a Klebsiella pneumonia?
Immunocompromised people.
Alcoholics, cirrhotic, diabetic, and immunocompromised people.
Yes, sir.
Any other important features for Klebsiella pneumonia?
So there could be possible complications like lung abscess. Yes.
Yeah, okay. The upper lobe,
Yes, sir.
unlike other pyogenic pneumonias, upper lobe dominance is commonly seen.
Yes, sir.
Usually predisposing factors are commonly seen. It affects the multiple lobes and it produces classical color sputum. And then of course, it breaks down very fast. It's necrotizing type of pneumonia and cavities are produced early. And it produces pleural involvement. Pleural involvement is a characteristic feature that produces encysted pleural fluid. These are the very characteristic features of Klebsiella pneumonia. And when you look at the young person, 20-year-old soldier getting pneumonia, which possibility comes to your mind first?
Because he's HIV, any immunocompromised states like HIV, or he has history of alcoholism.
If he is not having any of these, young soldier, which pneumonia comes? The susceptible for which pneumonia? They get pneumococcal pneumonia. Pneumococcal pneumonia is a pneumonia seen in youngsters who are very healthy. Students, soldiers, policemen, university students. Not physical finding can use the extra in them sometimes. Other than the rusty sputum. What is in the rusty?
Brownish red.
It will be just like the coffee ground. As a research example I can give. Rust, you remember, just like that. That's a peculiar color. But these colors are rarely seen nowadays, although it is described. The colors are present. They are very good for us to make a diagnosis. They can make new colors specifically, others will be all non-specific symptoms. This is a young man. So sometimes these people have also blisters around his lips. It's called as labiality.
Yes, sir.
The young person, without any other predisposing factor, immunocompromised state, pneumococcal pneumonia would have come to your mind. But it's got classical features, one episode of rigor on early pleural involvement. The diabetes, drinking habit is there. Then of course, he is also having peculiar color sputum and oncopleuris is delayed, and he has got multiple episodes of rigor and This go.
Klebsiella.
Go.
Klebsiella.
Okay. How does this pneumonia behave in elderly individuals? How do they manage?
Usually elderly, they might have abdominal pain, hiccups, and symptoms of aspiration.
They don't come like this. Usually they come for dyspnea. Bystander or relative say, is this me? He does not have fever. He may not have. If at all mild fever, he does not expect anything. He doesn't complain of pain. He just practice me. Minimum amount of cough, dry cough may present. Fever may or may not. You may have the neuropathy symptom. Immobile, incoherent, small and over. But you may have important findings tachypnea and tachycardia.
Yes, sir.
Usually over the hypoxia and higher mental functions will be totally confused. Whenever they are off their color, whenever they say something wrong with them, they tachypneic and tachycardia. Don't wait for the classical symptoms, classical signs. They are having possibly pneumonia over X-ray. Pneumonia, bacterial pneumonia, we didn't say staphylococcus. How do they present?
So, fever, chills and rigors, dyspnea, hemoptysis, pleuritic pain, early pleuritic pain.
Okay. So they have cream colored mucum. They have some predisposing illness in them. Just like measles, whooping cough, diabetes, alcoholism, immunocompromised. Important picture is it produces thin walled cavities. And first, they flew up pneumothorax. So this is very classical picture of.
Sir, excuse me. Sir, you're breaking up a little bit.
Pardon?
Sir, you're breaking up a little bit. It's not audible for everyone.
Now you are hearing?
Yes, sir.
Yes?
Sir, could you use a mic, possibly?
Are you able to hear now?
Yes, sir.
Okay. The pneumococcal pneumonia also occur in barracks, boardings, where people are crowded together. What are other factors for pneumonia?
So, any predisposing factors could be smoking, any upper respiratory tract infections, past history of.
How does smoking predispose for pneumonia? Smoking takes away your cilia of your epithelium and your discomfort of your epithelium. The first line of defense, namely ciliate epithelium of the respiratory system, will not be there. What's the point?
Yes, sir.
Same way respiratory infections, viral fevers, they all take away your first mechanical barrier for infection, namely the epithelium and the cilia. If you work in a very dusty environment, again they may have the same problem. Recurrent infection may occur. If you are having some amount of protection mechanically, you have a lot of hair in your nose, ciliate epithelium. There is some filter that takes place. Subsequently, you got cellular immunity, you have got humoral immunity. Whenever it's taken off, alcohol is something, diabetes is something, opioid addiction is something else. If you are living in a crowded environment, you are inhaling toxins, you are creating inhaling solvent, or you are exposed to some dusty environment, COPD, can make you susceptible for pneumonia. Suppose you have transient loss of consciousness during, say for example, a traffic accident, fell from bike. The transient period will make you susceptible for aspiration. So whenever somebody is coming to pneumonia, always think that he aspirated. People get aspirated in two scenarios, then they get drowned. When they get drowned in water, or when I get drowned under alcohol. Okay.
Yes, sir.
Drowning of two types, alcohol and water. Loss of consciousness, that is during anesthesia procedure. And where situation where your throat is anesthetized, those procedures, soon after you take food, you may have take. You have problems of deglutition, like cerebrovascular accident, transient of difficulty to swallow food can create problems. So these are all things that case for pneumonia. So you have got a risk factor. If you are having ERP, if you are having achalasia, these are types of problems. The third group producing problems. So basically, this gentleman is from community. So what type of pneumonia has got?
So, Klebsiella pneumonia.
Community acquired pneumonia. Community acquired pneumonia. And there's another entity called as nosocomial pneumonia. Again, the classified in two headings. One is hospital acquired pneumonia and ventilator associated pneumonia. Suppose you are admitted to for some reason. After 48 hours, you develop fever and other signs. We call it as hospital acquired.
Hospital.
If you have undergone an intubation, ventilated, then after 48 hours you develop patches in the X-ray or fever suggestive of pneumonia. We call it as ventilated associated pneumonia. The reason why you classify like this is it is true. What can be a positive organism? So here we have what is called as community
Acquired
pneumonia. Then we are thinking whether it's a typical community pneumonia or atypical pneumonia. Second step. What is atypical?
pneumonia caused by mycoplasma. They do not have typical pneumonia-like features. They have scanty sputum. Causative organs can be mycoplasma, chlamydia, anaerobes, etc.
Okay. So they have got some important features that is different from community pneumonia, classical type. Classical pneumonia is abrupt in onset, acute. These people have subacute onset. 3-4 days of minimal illness, they come like that. Not like abrupt onset of like in a healthy person. 2, fever will be minimum. 3, sputum will be minimum. And when you do the X-ray, only patchy findings will be seen, or interstitial findings, not like a low consolidation. Then atypical feature will be white cell count may be normal majority of the time. It's not leukocytosis, like pyogenic organisms. And when you do the gram stain, when you do the culture, you don't get any organism. These are the features that makes it atypical. Insidious onset, no sputum, no fever, X-ray also atypical, white cell count is normal, culture is nothing. So they will be called as atypical type of pneumonias. So what will be group of conditions coming under the group of atypical? When do somebody is having atypical? What are organisms for this? Typically you already said, your H influenza, you will staphylococcus, streptococcus, pneumonia, and then your Klebsiella. These are classical. What are the conditions coming under the atypical variety? Yes? Can you hear me? No? No?
Hello, sir.
Can you hear me?
Sorry, sir, my connection went. Mycoplasma, chlamydia.
Okay, mycoplasma, chlamydia.
Klebsiella.
No, Klebsiella is a bacteria.
No, sorry, sir. Legionella.
Legionella, very good. Okay, you said about Legionella. How do you recognize Legionella?
They might have associated features like GI symptoms, diarrhea, hepatitis, myalgia, hyponatremia, etc.
Who gets it usually?
People who have consumed, it's consumed through aquatic water sources.
Usually seen in people who are elderly. One, two, what's called legionnaires pneumonia. What legion? Have you heard something called Legion of Mary?
No, sir.
The group.
Basically, that is what went wrong. ഇല്ല ആശാനോട് പറഞ്ഞു ഇത് ആശാനോട് പറഞ്ഞു
Legionella, but milder form of illness. That's called as vomiting. Don't worry about that one. So since you said about the now you said about mycoplasma. How do you recognize that?
In mycoplasma anemia, it could be an insidious onset. There might be associated symptoms like erythema nodosum, rashes, myocarditis. Erythema nodosum.
What rash you get? General examination or the findings you may get. You may get anemia because of hemolysis. You may get jaundice because of hemolysis. And then patient may complain of something here. What is the spot? What's the spot? What is laryngitis?
Sorry, sir. So it's breaking up.
Pardon?
So it's not clearly audible.
What about laryngitis?
It could be an associated symptom of mycoplasma.
What is it? What's laryngitis?
Inflammation of the meninges.
Right now.
The meninges of the brain.
Laryngitis means. Or is something related to the ENT problem?
Sir, I'm not sure.
Not sure. Okay, I think it is your pressure of ENT, your expected laryngitis affects the external ear, tympanic membrane. You get ear pain as a symptom. So, what's the treatment of choice for mycoplasma?
Again, macrolides.
Okay, macrolide tetracycline can be given. So, you left over a group of conditions. One is viral pneumonia. No?
Yes, sir.
Now, before we go into the organism for the viral pneumonia, tell me how to differentiate viral pneumonia from bacterial pneumonia. Right?
In
Your notebook, left side bacteria, right side virus. Other point you write symptoms, signs, investigation. Okay.
sir, in viral pneumonia, in symptoms, the patient will have dry cough or scanty sputum. Patient will not have major symptoms like
Symptom-wise, they are typical. But dyspnea will be very much more. Patient main symptom will be very much dyspnea, toxic. Okay, tachypnea, hypoxic. That's the picture in viral pneumonia. Bacterial pneumonia fever, tiger, will walk, expectoration, sign. What sign you will get? Viral pneumonia.
signs will be usually absent, not that of normal pneumococcal.
That's right. In bacterial pneumonia, signs will be proportionate to the viral symptoms. In viral pneumonia, signs will be minimal or nil, but symptoms will be bring. If you do X-ray, what will you find?
Maybe a reticular pattern.
X-ray will be showing lot of changes in the X-ray. Signs are nil, symptoms are plenty, X-ray will plenty signs. Unlike bacterial pneumonia, symptoms are proportional to signs, and X-ray is exactly the of physical findings will visit the particular area or physical findings you can find the sign. So that's how you differentiate viral from bacterial pneumonia. So what are the viruses producing pneumonia?
Influenza.
Influenza A and B, that's right. Who are the people likely to suffer with?
People are not taking vaccinations.
Elderly, COPD patients, CKD patients, diabetic patients, coronary disease patients, immunocompromised patients. These people patients must take yearly vaccination for influenza.
Influenza.
Any other
H1N.
H1N1?
Yes,
What is the choice for H1N1?
sir. Respiratory syncytial virus.
You can call H1N1 pneumonia. Have you heard something about MERS?
Yes, sir. Middle Eastern. Middle Eastern.
Another type of virus recently came and gone. Now what's the virus going on all over the world? Happening.
Corona.
Corona. So you know, so everything is not about this viral pneumonias. Important points are they come in epidemic. So that epidemic that cannot help you to make organism. Because fresh organism and you should not forget them when you have pneumonia. So that's your treatment. Is having problem what you want, but I still finding expecting.
Sir, we'll ask for a blood examination.
You can examine the patient, still finding
In inspection, he might have diminished respiratory movements on right side. On
yeah. The affected lobe will have all the classical findings of consolidation,
consolidation.
right? Dullness, decreased movement,
Vocal frame is increased.
and tubular blood sound, depending upon the stage of the disease. And crashes, of course, will be there. Okay. So, in the case of bacterial pneumonia, you expect to find slow involvement, bilateral signs, and then majority of the time these days you find that the classical time to consolidate is seen in only 1/3 of the patients. 2/3 will be having only status. So absence of these signs did not make you think that this patient does not have signs, but they do have signs, but they are very, very similar. So, it's a hepatological pneumonia, again the same thing, bilateral disease. There is no restriction, pneumothorax or pneumonia. That's more for this unit. So what is examining the patient? You are going for investigation. What are your investigations you want to plan? Hemogram is definitely glucose exploration,
So then we'll do a sputum examination.
a gram negative or culture shows blood data.
Then we can do
Pneumonia, you have to get the organism in the sputum. So in such cases, you may go for urine antigen for pneumococcus. If you're suspecting Legionella, you can go for urine for Legionella.
yes, sir.
Specific investigations are available, and you may go for genetic study, PCR and so on. Then you have patients who cannot expect it at all. Just patients, only way to make a diagnosis by looking for antigens, the urine. You get for PCR and you may get diagnosis.
Yes.
Okay. So one advantage of getting sputum is you get the culture sensitive report. But if you get antigen, you may get the organism, but you do not know which antibiotic to be given. When you are in doubt, sometimes no calcitonin is done. Very expensive investigation, $3,000. When it is a bacterial infection, other test infection you will not have to do it. So that may also be done. Okay. So for bacteria, you have this investigation. Coming to the viruses, you have to go for antigen test, PCR test, investigation for viral pneumonia. Once they have made a diagnosis of pneumonia in this patient, young man, so any person, pneumonia, how they are severe.
We can do the curve 65 criteria.
That's right. That's for people above 65. So one point is for 65, another point is for confusion, elevated urea, respiratory failure,
Yes.
hypotension. So how does it help you? Suppose it is less than 1, what do you do?
We can do an OP management.
Management, pneumococcal pneumonia. Which is 2, what will you do?
For 2 and above, we do IP,
It's more than 3. You require
ICU admission.
management. If one of people who are admitted in the ICU, commonly,
Usually elderly, immunocompromised patients, people who have
higher mental functions also. Hypoxia is there. The respiratory failure is there. ADP shows low oxygen. They must be in the ICU. If you talk about the death is one is respiratory failure, second is shock. Okay. So these are definite indications. And of course the people who are at high score, who may have bad prognosis. Another bad prognosis is leukopenia, the gas infection. It's a very bad sign. And they must be also be in the ICU. Okay. Multilobar involvement or multiple organ involvement. So that time they will be in the ICU. Okay. So pneumococcal pneumonia, what do you find that way?
pneumococcal
You find the area of
consolidation.
consolidation. What is the term consolidation?
It's the exudative solidification of lung parenchyma.
Which is solidification and parenchyma is called as consolidation. What are stages through which it passes?
Stage of congestion, stage of red hepatization, stage of gray hepatization, and stage of resolution.
Why they are called hepatitis?
Because it resembles the liver's surface and
These are not. So everyone knows the resolution. Resolution does not take place, it becomes problem. Okay. So what do you do for this patient with pneumococcal pneumonia? What antibiotic can
usually we can start with knee macrolides.
only we give for amoxicillin. The type of antibiotic is usually decided region-wide. The spectrum UK may be different from spectrum in Gulf, may be different from states, maybe from Australia, may be different from India. India itself, different hospitals have different spectrum. Commonly, in our country, in our issue, possibly, pneumococcal pneumonia usually responds to amoxicillin. The patient significantly, you must go for erythromycin. Okay. If the patient is having very poor prognosis time, before we move on, then you will go on to give higher antibiotic like for class.
Yes, sir.
And if there are contraindications for that, you can always go for respiratory nodes. What are they?
Levo.
So that antibiotic can be given. How long you continue the antibiotics?
Usually for around 2 weeks.
The minimum criteria is you must be at least for 2 days after temperature has become normal. No paracetamol, but no fever, or whatever is one criteria. Second criteria should be minimum duration of treatment must be for 5 days. Minimum duration of treatment is what?
5 days.
5 days. But when the pleura gets involved, infusion occurs, enlistment occurs, as in case of Klebsiella pneumonia, then when the pneumonia is already broken down to its cavities, those patients may require 4 to 6 weeks. Pneumococcal pneumonia, 5 days good enough. After 5 days, 2 days after the fever gets normal. The killer staphylococcus takes more time. What is the extra pattern? Klebsiella pneumonia.
The upper lobes are usually involved.
Protected here.
It could be a multilobar involvement.
No, very good. What else?
Bulging fissure sign can be seen.
It's a function.
Uh,
Maybe. What about staphylococcus?
Pneumatoceles can be seen.
Pneumothorax. Thin walled, low bubble appearance X-ray mix. Viral pneumonia what do you expect to find?
Reticular pattern.
Particular pattern or interstitial pattern. What is the bronchopneumonia? Broncho.
In bronchopneumonia, it's usually we might see atelectasis in chest X-ray. There it's patchy involvement is seen. It's
Involvement on the bronchiole. Bilaterally seen. That's called bronchopneumonia. But the classical communicated bacterial pneumonia there was not classical lobar consolidation. Unaffected lobe is properly consolidated. The terms must be very clear. And interstitial shadows are the characteristic appearance in case of viral pneumonia. Viral pneumonia is not the manufacturer.
so
Big loss. The experiment zone is affected classically. So the pneumocystis carrying pneumonia may find big zone is affected. When we suspect pneumocystis,
any history of AIDS, HIV.
the infection, COPD patients also, they have persistent fever, and people who are having interstitial lung disease, or immunocompromised, compromised. Usually they come with a sneer and Nixon ratio, classical areas of consumption. Okay. What are the complications of
It can be unresolved, or it can go for lung abscess, empyema.
It is not responding to antibiotics. What are the possibilities in your mind?
It should have been already complicated by any empyema or lung abscess.
Very good.
Patient could be immunocompromised, or maybe it could be a TB pneumonia which needs antituberculous treatment.
I think you are wrong choice of antibiotics. Complicated. What are the, or rarely, drug fever. What are the complications? You already said lung abscess is one, thin pneumonic effect is two. You said there could be empyema. Yes.
Yes, sir.
Any other? Any infection can be goes for a metastatic infection. Suppose if they say vulnerable scan physical and the incorporated pneumonia may produce healing in the brain abscess. If possible. Some of them go for respiratory failure, some of them go for hypertension, shock, others may go for MBBS. This is a classical reason for complication. So basically, as you have the pneumonia patient stop, you always cover sputum, examination gram stain and culture. You just pick it for documentary. Maybe it will be in a structure. But you have to early blood pressure make you conclude and you know the pneumonia lesion like for urinary antigens. And feature the treatment for mycoplasma and chlamydia source of viral pneumonia. Basically, I was trying to highlight how do you appreciate the that weight, good, instead of the pneumonia. Can we check weight? Just one, critical version, critical. It is a viral, chlamydia, mycoplasma, legionella, and pneumonia. From the bacteria, streptococcus, staphylococcus, different symptom, signs, sputum, different X-ray, different word of individual. When he talked briefly about the severe index criteria, when he said about the pathology, comes to different primary dimension. What are the possible things? Differential diagnosis.
Maybe a pulmonary.
Consolidation taking place in the cellular activity makes it
exudative pleural effusion?
No. The question is, you said the solid is defined as exudative.
Solidification of lung parenchyma.
So, these are situations where the air containing lung can be solidified.
A pulmonary infarction, pulmonary edema,
Rarely, yes.
maybe a pulmonary tuberculosis causing fibrosis.
Pneumonia fibrosis can confirm it, like this patient, diabetic patient is a likely candidate. Okay. Then you have
Any tumors, any
tumor is excellent. So if there's a clumping, it will be careful. Okay. I
Yes,
think we have covered almost everything. Today's class was exclusively based on a history of pneumonia, how to look at it in the comorbid condition. That's why the history is a diabetes, and your beta also. You may be aspirating in between.